So once again, welcome to today's informational webinar on medication-assisted treatment in rural Oklahoma. Today we'll be talking about a new provider training and mentoring project for primary care practices. As I mentioned, my name is Bob Madden. I work for the American Institutes for Research, and I will be your host for today's webinar. Before we start, just a couple of quick housekeeping rules. The session will be recorded. When we do the questions and answers at the end, the recording will be suspended. Slides for the recordings will be posted on our website, which is up and available. It's oklahomamat.org. If you wish to ask a question, please use the chat to organizer function for any logistical questions, and chat to all for questions for the speakers. We are doing this program. It's being funded through a grant from the Agency for Healthcare Research and Quality, also known as AHRQ, and is one of 4 projects funded by AHRQ in response to the needs of rural communities facing high rates of opioid-related mortality, misuse, and abuse of prescription narcotics, illicit drug use, or overdose. The project is led by the American Institutes for Research, AIR, and we are a social science and behavioral research organization. We are joined by partners who offer extensive experience in primary care practice improvement, rural health, addiction medicine, treatment of opioid use disorders, telehealth, and clinical education and training. Our partners include the Oklahoma Department of Mental Health and Substance Abuse Services, who work to promote productive lifestyles and set the national standard for prevention, treatment, and recovery for those affected by mental illness, substance abuse disorders, and domestic and sexual violence. The American Society of Addiction Medicine, or ASAM, is dedicated to increasing access to care, improving the quality of addiction treatment, and educating physicians. ASAM has a proven record of advancing addictive medicine to achieve increasingly better outcomes for individuals and families struggling with addiction. And also the ECHO Institute, that's the Extension for Community Healthcare Outcomes at the University of New Mexico Health Sciences Center. ECHO helps link specialists and other experts with primary care clinicians through tele-ECHO clinics. We are also pleased to have with us 3 consulting physicians, Dr. Paul Seal, Dr. Lane Subera, and Dr. William Yarborough. In addition to the trainings and remote tele-ECHO clinics offered by our partners, ASAM and the ECHO Institute, clinicians who participate in the MAT expansion program will benefit from the expertise of 3 consulting physicians staffed on the project. Drs. William Yarborough, Lane Subera, and Paul Seal brings extensive experience implementing and maintaining MAT in their clinics. Ad hoc consultations with these experts may be requested through the project team to help you work through challenges and identify ways to help you succeed in your efforts while adhering to the evidence-based clinical approach prescribed by MAT. Brief biographical sketches are available on the website. You'll get to hear from Drs. Seal, Subera, and Yarborough later during today's webinar. Just very briefly, the webinar has 3 goals today. I won't read all of these bullet points, but we want to give you a brief background on opioids in the state of Oklahoma. We also will cover medication-assisted treatment expansion program itself, tell you about the goals of the program as well as the training opportunities, the physician support that I just mentioned, as well as care coordination support. finally, there is also a section talking about the anticipated time and resource commitment that's expected from you and your practice if you should decide to participate. We'll try to leave plenty of time at the end for your questions and answers. We'll try to get through the presentation itself in approximately 40 minutes, leaving 20 minutes for questions and answers. At this point, I would like to turn the presentation over to Dr. William Yarbrough, who will talk about the opioid epidemic in Oklahoma. Dr. Yarbrough, the mic is yours. Dr. Yarbrough, you may need to unmute yourself.
Okay, fine. It won't let me unmute it, so it's unmuted now. So, thank you. I'm going to just discuss briefly the problems that we have in Oklahoma and nationally with prescription pain drugs and illicit drugs as well. And that opioids is a term that includes both drugs that are essentially synthesized or produced directly from opium, such as morphine and heroin, and then what we commonly call semi-synthetic drugs, such as hydrocodone, oxycodone, fentanyl, which is, I believe, pretty much a purely synthetic drug, and there are other synthetic drugs that are not derived from opioids but affect the brain in the same way. A lot of these are legal substances that are used to treat pain and have been for years. Most of the deaths from prescription drugs in Oklahoma involve prescription painkillers in 2014. I suspect that's still viable, although there may be some slight decrease there. The other thing that's occurred in Oklahoma that had not, in my career at least, never had been here was heroin in significant amounts. There's been an increasing amount of heroin seen in Oklahoma. And in the treatment business, we're seeing more and more people who are using heroin. The rate of heroin use is not quite as high in Oklahoma as it is in some parts of the country, but I think we're probably getting there. So heroin is, I think it's very important to understand, heroin is a substance chemically called diacetyl morphine. So heroin is not something significantly different than morphine. So just so that people understand, we're not talking about a different class of drugs. So go on the next slide. This is just a map showing where the highest rates of mortality are. You can read the legends and study this map. One of the most important things in some of these counties, there's a completely unmet treatment need available even in some of the higher counties, and there's a very low ratio of Suboxone, buprenorphine prescribers, which we'll discuss later, to treat these people. In some of these counties, there's none, and the ratio of that in Oklahoma is much lower than in some other states in the nation. So, next slide. So, what is medication-assisted treatment for opioid use disorder? It's defined as combining medications, hopefully with psychosocial services and sometimes other wraparound, as we term, services to provide a whole patient approach to the treatment of opioid use disorder. And like a lot of diseases, the amount of different services people need may vary, but to get the best outcomes, I think all of these services being available improves outcomes. So methadone has been available a long time through methadone clinics. Those typically only exist in urban areas and is not very, particularly for rural areas, has not had much effect. There are people I see that drive from long ways every day to get their methadone, but you don't see that out in the rural areas, and it's not an office-based treatment. Buprenorphine, which there's several different formulations of, is a partial opioid agonist. Not sure it's an antagonist, as the slide says, but usually provided in a formula that includes naloxone, and that's where the term Suboxone comes from. It's buprenorphine mixed with naloxone. It's important to understand that the naloxone that's mixed with buprenorphine was just something that was added to this to prevent intravenous abuse of buprenorphine, and that orally it has little effect. There's a lot of confusion about that issue. And then there's naltrexone that can be given orally as, and then there's the once a month injection called Vivitrol, which is long-acting that was originally, I believe, designed to treat alcoholism, but has some decent efficacy in treating opioid use disorder in certain patients. So that's just a brief overview of when we talk about medication-assisted treatment, what we're actually generally talking about. So is that next slide? Are we going on to the discussion?
Yes. If Doctors Subera, Yarbrough, and Sale, would you please share some of your own personal experiences with being an MAT provider here? Thank you.
Well, I'll go ahead and talk. I think one thing, I'm an internist. I've had somewhat of a variable career. Was an emergency department director for 10 years. I'm a certified pain management as well as addiction medicine. And I'll have to say that the most fulfilling thing I've done in my career is treating addiction with medications and being part of a team that treats addiction with medications. It's an extremely positive, in my opinion, patient treatment modality. It's very satisfying. It's not 100%. You have to work sometimes with patients, but I would just have to say it's far more satisfying to me than ever treating diabetes and hypertension, et cetera, those type of chronic diseases. I didn't see it that way at first, but after I've done this for a long time, I realized that really I'm involved with salvaging young people's lives, futures, families, children's, and it actually works. So I could give you several examples of that, but I think just the overall feeling of this is that it's as opposed to how most people might see it, it's an extremely, for me at least, positive part of my practice, much more than anything else I do. It took me a while to get there and understand that, but that's how I feel about it. So I'll just turn this over now to Dr. Subera and let him tell you his experience. Or I can ramble on.
Dr. Subera?
Oh, thank you. I was muted by the system. Yes, my name is Lane Subera, and I've been doing MAT for about 12 years now through my primary care practice, and it wasn't really something that I started out intentionally to do, but there was definitely a need in my community, and I'm glad that I was eventually able to step up to the plate and take the training to start the therapy. I currently have about 95 patients on my panel, and like Dr. Yarbrough says, it really feels like a great honor to help these people get back on their feet, and you really see some amazing turnarounds. I think one of the drawbacks about primary care in general is you don't really get to do a lot of heroic things like the guys in the big facilities do, but this can really feel that way at times. You know, in our practice, we try to get people off of the medication over the course of a year, and I think that's successful around 30% of the time, and of the remainder, a lot of people take it for several years before they're ready to taper, and we try and keep them on the medicine and support it until they get into a better environment where they can stand on their feet. You know, we had talked earlier about heroin, and we just had a young man in our community of 7,000 people overdose on heroin here in the last week, and so it's really a prescient topic, and I'm proud to be part of the program to help spread treatment for this problem. So, thank you.
Thank you, Dr. Subera. And Dr. Seal, would you like to finish up, please? Dr. Seal, on your control panel, there's a small microphone icon. If you just press on that, you should be able to speak. Should be able to hear you, rather. All right, I think we may have lost Dr. Seal. Sorry about that. We will, if he calls back in, we will pick up his presentation at that time. Thank you very much, Drs. Yarborough and Subera. I would now like to turn the microphone over to our project director, Dr. Susan Heil, who will discuss the Rural Oklahoma MAT program itself. Susan?
Bob, can you hear me?
Yes, we can hear you just fine.
Great, excellent. Can you take us back to slide 11, please? Yeah, program goals, that's perfect.
Yep.
Thank you. Sorry for the technical glitch. My name is Susan Heil, and I am a researcher here at the American Institutes for Research, and I'm the principal investigator of this grant. I am a former Oklahoma resident and pleased to be working with the state and our other partners. I am a former employee, actually, of the state agency that we are partnering with on this grant. So I have for a long time had a history and interest in behavioral health and the substance abuse world, and when this opportunity came up through ARC, was very happy to be able to reconnect with my colleagues at the state of Oklahoma and hopefully develop a program that will help to increase access to care for those who need it in rural Oklahoma. Through supporting providers such as yourselves who have an interest to respond to the epidemic that was described earlier by Dr. Yarborough, and that sweeps not just Oklahoma but the nation as a whole. So I'm pleased to be here today, and I thank you all for joining us to hear a little bit more about this project. Our project does not operate in a vacuum. There are many efforts underway in Oklahoma which we acknowledge, and we have but a small piece of Oklahoma's overall total efforts to try to address the opioid epidemic. We work in concert and in awareness of naloxone distribution efforts that are underway, pain prescribing guidelines that are being developed and have been developed by the state and are being revamped by the state, and other safe prescribing initiatives and other efforts underway within the state. So our simple piece, sliver of this total solution is to try to help expand the access through rural primary care through this training and mentoring program. We are trying to expand access to people who are living in 39 rural counties. So we are located in doing this in 2 waves, which I'll discuss in a little bit. But the primary focus on this webinar is toward our first wave, which will be in the northeast and southeast counties. And we are attempting to implement this program to not only expand access, but ultimately reduce mortality rates, improve the quality of life of folks who are opioid dependent in rural Oklahoma. And as I noted, really the key to, I think, ensuring the adoption and continuation of quality medication-assisted treatment is to ensure that providers have the supports that they need to effectively screen, treat, and help patients to achieve and sustain their recovery from opioid addiction. We do have in our training program, our program is eligible to providers that are physicians, nurse practitioners, and physician assistants. Federal regulations have changed recently to include nurse practitioners and PAs as eligible to obtain the waiver to provide buprenorphine from the office-based setting. That was not previously the case prior to, I believe, last fall. So we do have this training program to help continue to lay the seeds of training and support and knowledge about addiction medicine among folks in the practice as a whole. We do want to acknowledge that buprenorphine for addiction treatment is on the exclusionary formulary for Oklahoma NPs. Our partners at the state are looking into coordinating with other state agencies to investigate what the justification of that is and to potentially work on a solution. We are a 3-year grant, so we have a fairly long lifespan there in the state with you all. So hopefully as we believe that the program is valuable to nurse practitioners and PAs currently for the the experience that would be gained in addiction medicine, and we just wanted to acknowledge that about the exclusionary formulary piece of it. And legislation changes over time, and formularies do. So anyway, we offer that, and just wanted to note that as well. You can go to the next slide, please. So as I noted, our first wave includes providers in the Northeast and Southeast regions of the state. And we are in 18 counties in the Northeast and Southeast. And this program, we're in recruitment for Northeast and Southeast regions through April. And that program will be rolling out in June. And then we are recruiting also for a second wave, which would be North Central and South Central regions, the noted rural counties in the South Central and North Central regions of the state, which that program is slated to begin in December. You can go to the next slide, please. So just to overview a little bit, you heard about kind of the access that you've got to our physician consultants. So mentoring is available from your physician colleagues, but we do offer other supports as well, including rich training opportunities and a training program to help you implement MAT in your practice, to help sustain your efforts and assure your success. Each of these components, the training opportunities, case-based learning through the ECHO model, each of these will be described in a bit more detail, as well as MAT-related supports for coordinating care. As Dr. Yarborough noted, there is not just the pharmacological component of MAT, but also realizing that folks with opioid use disorder often have other behavioral health and psychosocial needs for recovery support, such as housing or transportation, et cetera. And so ensuring that those services are acknowledged, that there often are such needs, but also helping providers to be able to make referrals where necessary and understand sort of the linkages to those systems within the state. And with that, I would like to turn to, we'll talk a little bit more about each of those aspects of the program, but I'd like to turn to Dr. Seal to talk a bit about the training program that we're offering to participating clinicians. Dr. Seal? Dr. Seal, we can't hear you if you're speaking.
Susan, it's saying that he has self-muted, and we cannot unmute him from here. So, Dr. Seal, if you can unmute yourself.
How about now? Can you hear me now?
Yes, we can. Thank you very much.
All right, great. So these training and education opportunities are really a tremendous benefit in two regards. One is that they really help you manage these patients, and the other is that they also help you meet your own CME requirements for ongoing certification. And as the top box on this slide demonstrates, the American Society of Addiction Medicine has put together a Fundamentals of Addiction Medicine program for which you can actually get a certificate of recognition if you complete a total of 40 CME hours. And so that's a nice credential that sort of demonstrates you've done some extra training in this area. That is not required, but the things that would be required for you to actually participate in this program, first is the top box on the right, and that is the treatment of opioid use disorder course. This is required to get the DEA number that you need to use to prescribe buprenorphine. And so 8 CME hours are required for physicians, for PAs and nurse practitioners. There's an additional 16 hours required, but the 8 hours would certify anyone who wants to get the DEA waiver that would allow them to prescribe buprenorphine. And typically, one of the most popular ways to do that right now is a combination of 4 hours of individual reading followed by 4 hours online. We'll also provide the 4 hours live a little bit later in the spring in Oklahoma, so you can also attend that course, and we'd have a chance to meet face-to-face. In addition to that, we strongly encourage, if you're going to treat opioid use disorders with buprenorphine, that you do the middle box, and the slide says Fame Tele-Echo Clinic. So this is a fairly new technology I've just only recently become acquainted with. This is an effort out of the University of New Mexico where they do distance learning, and if you participate, you actually, if you have a camera, your picture shows up with the other clinicians who are participating. Typically, these are 2-hour sessions. They start with a presentation of a case, and then that case is discussed by the panelists. You have 3 expert panelists. They'll discuss the case, and they encourage you to send your own cases. So to sign up for the webinar and send any challenging cases that you have. Then in the middle of the session, there's a didactic teaching about some aspect of medication-assisted treatment, and then followed by a second case. So it's an ideal way that I think a lot of us enjoy learning. We like case-based learning. We like a chance to find out how to do a better job with our difficult patients. And so those come in 2-hour blocks, and once you've done 4 of those, then you've got sort of the 16 hours of the core that you need to manage substance use disorder with medication-assisted treatment. If you want to keep going and get the 40 hours and the certificate, then other options that are available to you in the bottom right corner, there are elective topics that will be available through the ASAM website. So that's asam.org, and there will be lots of things to choose from on topics that hopefully will interest you. On the bottom left corner, there will be an opportunity for a course on safe opioid prescribing. Again, you can do that live later in the spring. I think that meeting will be in Tulsa. Stay tuned for news about exact details of when and where for that workshop. And then in the upper left corner, there's a course called Addiction Medicine 101. It's kind of an introduction to sort of basic concepts of managing people who have problems with alcohol use disorder, substance use disorder, and there will be an 8-hour live workshop on that, or there will be a 5-hour online CME option for that. So a lot of great opportunities for CME, and at the bottom, as it points out, there'll be a collection of resources and tools for providers. So different resources and tools that people find helpful in managing these patients will be available to you again through the ASAM website. If I can, I'll just take a moment to tell you about my experience with providing buprenorphine to patients in my area. I got certified. I'm a family physician. I'm actually from Texas, so not too far from where you folks in Oklahoma live and practice. Went to medical school in Texas, and then later moved to Georgia, where I did my residency, and now I teach in a family medicine residency program. But as a family physician, I had a personal interest in addiction. I got certified in addiction medicine, and I have to say, over the course of most of my career, didn't get lots of patients walking into my office saying, I have a problem with alcohol, I have a problem with drugs, can you help me? In fact, just the opposite was my experience. These folks a lot of times didn't recognize they had a problem, didn't want help. And about 7 years ago, I decided to get a waiver to prescribe buprenorphine. And it's been such a refreshing experience because these patients, what it seems to me happens is that the opioid use disorder escalates very rapidly. So oftentimes over a period of a year or 2 or 3, people get highly dependent on these drugs. They get withdrawal if they try to stop. It wrecks their lives, their finances, their family, their job, and all their life revolves around opioids. And then they hear about Suboxone and are desperate for help. And so these are patients that come to my office seeking help, and many of them highly motivated, as was commented on earlier. It doesn't work for everybody, but probably somewhere between a half and 2/3 of the patients that I have treated have done well. And it's dramatic to see what happens in their life once they're not spending hundreds to thousands of dollars a month on opioids, and once they're not spending their life trying to keep from going into withdrawal. So this is a safe medication. We can easily prescribe it in family in primary care, and it dramatically turns people's lives around. They can become stable family members. They can hold a job. They get their finances back in order. After a relatively short period of time, many of them become very much like my ongoing hypertensive patients that come in every 3 months or so, get their refill, and then at whatever point they want to, they can slowly taper off the medication. So I had my questions and my concerns initially, like I think many primary care docs do. Are these people just going from one addiction to another? Are they going to have a negative impact on my practice? I have to say, for the most part, those have not been the case. We've had disruptive patients who are on Suboxone and disruptive patients who are not on Suboxone in my practice, but the patients really fit in very well. We find a lot of these patients are in our practices already, and it's extremely rewarding now when we see patients who have gotten into trouble with pain medicines to offer them a treatment that we can provide right there on site. So I hope many of you will take seriously the opportunity to get a DEA waiver so you can treat patients with opioid use disorder, and I think you'll see what really is almost like watching a miracle happen as these people go from active addiction to agonist therapy and a restored personal life. So those are my comments. Thanks so much.
All right. Thank you, Dr. Seal. Susan, would you like to introduce Crystal?
Hi, thank you. Can you hear me?
Yes.
Great, thanks. So I thank you, Dr. Seal. I'm glad you were able to add your stories to those that were previously shared by Drs. Sabera and Yarborough. I want to also talk about our MAT coordinator and have her introduce herself. We have, through our partnership with the Oklahoma Department of Mental Health and Substance Abuse Services, ensured that there's a position available and operating to help provide support for you, as I noted earlier, for referrals, for understanding the larger services landscape, I guess, that is the contextual surround in your areas, to the extent that folks might need some support with that. We also understand there's variation in the practices that will be participating, and some practices may already have more connections to other service providers in their area. Some may have some integrated experiences with behavioral health in their own practice. So we realize there's that variation, and very much will work individually with practices to ensure that these linkages, that Crystal is able to support you and we're able to support you in that capacity in a way that makes sense for your practice and what is already going on there. So Crystal, if you could take a few minutes and just talk a little bit about your role and your experiences.
Sure. My name is Crystal Norman, and as Susan said, I work for the Department of Mental Health and Substance Abuse Services, and I'll be serving as the MAT coordinator. I spent the past 8 years or so working in community mental health and substance use disorder treatment here in Oklahoma. I have experience with program development and implementation and management, as well as experience in provision and supervision of direct care of individuals with serious mental illness and substance use disorders. This project is particularly relevant here in Oklahoma. As we've stated, there's a lot of people currently facing challenges and problems with opioid use disorders, and we face a lot of challenges in helping those clients access the treatment for that, especially in rural Oklahoma. With the addition of more physicians providing that medicated assisted treatment and working together with the community resources and the behavioral health treatment available, I think that we'll see a significant increase in their success in addressing and their treatment issues and seeking long-term recovery. So I look forward to assisting in helping you and your clients access those resources.
Thanks so much, Crystal. I wanted to note that one of the aspects of the program is that we are hoping that each practice will have someone who will serve a role as a practice liaison, who would be Crystal's primary point of contact and the program's primary point of contact. Crystal will be doing site visits with your practice to help with, practice facilitation as MAT is implemented, and along with the physician consultants, be able to be a resource to you for helping with any challenges or questions that emerge. You go to the next slide, Bob. So I wanted to talk a little bit about timeline, and then, as Bob noted earlier, the anticipated time commitments. So for the timeline that's posted, this is for the first wave. So this is for the Northeast and Southeast Oklahoma time schedule as we currently plan it. There is a second schedule for the other participating regions and counties. So if you are on the phone representing those counties, we will have a second schedule later on. But for this wave, our recruitment is going on through April. In May, we will have a half-day pre-implementation training where we will talk to you about various topics such as consent protocols. We will be talking about and introducing any of the hardware and software needed to participate in the ECHO sessions. Practices who are participating will get webcams and the needed software to be able to participate in those sessions. We will be talking and introducing you to the evaluation tools that we'll be using. I'll talk about the evaluation in a few minutes. The processes and procedures for specific aspects of the intervention, thinking through referral protocols or referral templates, if you will, and what the role is of the practice in data collection. I'll preview that a little bit as I talk about the evaluation. We also are going to be implementing a collaborative workspace for the website. So if you have visited the website, Bob said the URL earlier, it's Oklahoma, the full name of the state, oklahomamat.org. And we will be, right now there is no special feature or login membership on that, but we will be expanding the website to include having a space where folks can talk together about the project and share information, and we'll be able to provide some additional resources there. Based on things that have been contributed and are already in practice with our partners, the American Society of Addiction Medicine, and some of the resources that they have collected on their site as well. In June, for the first wave, the program will truly begin. And so we envision that between June and August, the completion of the fundamentals workshop that Dr. Seal discussed, as well as the waiver course, will happen for eligible providers who will then obtain the waiver. We think that folks should be up and running to be able to start prescribing probably around August or early September. We think probably in August. Participating providers who want to complete the full 40-hour program that Dr. Seal discussed will have 10 months to do so. So that is a feature. I know sometimes there's concern about being able to complete requirements in a very short period of time, but 10 months is available to do that. So hopefully that adds some flexibility to your schedule. And it is a program that will continue with our supports throughout September of 2019. Online training options will continue to be available. Participation in another ECHO clinic related to addiction medicine will also be available to folks participating in this. And the consultants and resources offered by our MAT coordinator for practice facilitation continue on. You can go to the next slide. Okay, I just want to briefly go through some of the elements of the evaluation. We do have goals of the project to not only learn about if these supports if these trainings and additional supports that are provided are helpful in helping to increase MAT in Oklahoma, but we also hope to use these successful practices, and I know our funder is truly interested in this, to be able to expand those lessons learned to help affect recovery for the lives of people who are affected by opioid use disorder more broadly. So dissemination is a key piece of our project, and to do that we need to understand what the outcomes and the impacts are of the project that we have implemented. So we do have an evaluation feature to assess the effectiveness of expanding access to MAT through the provider education, training, mentorship, and supports that are offered. The evaluation hopefully will improve our understanding of any barriers that there are to providing treatment for OUD, both within Oklahoma and in rural primary care more broadly, and how to address those barriers. We will use this information to improve MAT implementation and share that knowledge, as I said, with others across the country through dissemination efforts. So the key features of participating in the evaluation, first of all, there will be a readiness assessment. So the brief survey that we've developed that is at the practice level. So if there are multiple providers who are participating from a given practice, we only need one of the readiness assessments completed for the practice. There is also a staff and provider survey, which is at the individual level of the clinician participating, and that happens twice, both prior to the implementation and then at the 6-month mark. We will have clinicians also participate in consenting patients into the to be able to consent to give to share their data, to share data for research purposes in compliance with the federal regulations. So there will be a data use agreement involved, but from a day-to-day standpoint, in terms of treatment of patients, we will have your practice staff, your clinicians, or other practice liaison, or however we work that out individually within the practice, be able to consent patients and obtain, for those who provide their consent to have their data shared, we will be following up at the 6-month mark with the patient with a patient experience survey. So we understand not just the aspects of and outcomes of the training program for providers, but also what's been the experience of medication-assisted treatment and this program on the part of the patients who are receiving it. We will also, as part of the evaluation, ask that providers maintain a log of patients that are screened for OUD and positive screenings as well, so that we can get some metrics on for process evaluation. And at the end of the evaluation, we will be asking practices to participate in pulling medical records. We'll be providing an algorithm to pull medical records on those who have consented, on those patients who have consented to participate in the evaluation. So we will have a data use agreement in place. We will go through the consent procedures and have the data use agreements already in place by the time that pre-intervention training happens in May. That'll be part of the onboarding process. You might also be asked to participate in a brief interview about the experience. We are going to try to enhance and edify our quantitative data with qualitative information as well to learn more about your experiences as a provider in this program. And to offset the costs of participating and supporting the data collection, we do offer a small stipend. And it really has two components to it. One is to support, the weekly or daily recording of the log of patients screened and things that happen kind of on a more recurrent basis. But then there's also a component of the stipend that's based on a per patient, actually per data component, per time period of data collection piece of the pulling of the medical records to try to support that effort as well. So the price, the stipend varies a little bit based on whether you're a Wave 1 or a Wave 2 practice, because Wave 1 continues a little bit longer than Wave 2. But the details of that will continue to be shared with you, and we'll have more information at the time of the pre-intervention training in May, as well as in the onboarding documents as you sign on, so that you fully understand kind of what we're asking. You can go on to the next piece. So we've heard some, we know that time is tight for everyone, and we know that sometimes it's hard to commit to a full training program to the extent to which Dr. Seal talked about a little bit earlier. So we know that providers will decide for themselves really the level of commitment that they want to have or can have in terms of engaging with the trainings that are offered. So just to ballpark an estimated time commitment over the life of the project, we've come up with 3 sort of scenarios, if you will, to give you a sense of the time commitments that might be involved. And this is thinking through both the trainings and the evaluation time, as well as the site visits to talk with Crystal. So although we do encourage you to take full advantage of the offer components in the program, so if you do that, we're talking about the 3rd row on the grid, the entire ASAM Fundamentals of Addiction 40-hour program. So time varies a little bit also based on whether we're talking about your practice liaison's time, you're participating, if you're a participating NP or PA, because as Dr. Steele mentioned, the training requirements are a little bit longer, or if you're a participating physician. So the longest time frame or commitment is really noted on that bottom row. If you are someone who really just can only get the buprenorphine waiver, we're talking about the required training only. So that would be the 1st row. The required training only row is really the bare minimum of training. But again, since we are hoping to impact not just access to medication-assisted treatment and more folks taking up, more clinicians taking up medication-assisted treatment, we also want to make sure that that's good quality medication-assisted treatment to care for the persons with OUD. The middle row is sort of the happy medium. So those trainings that Dr. Seal mentioned were strongly recommended. The training components there are in that middle row. Just to give you a ballpark estimate of time as you make your decision to participate in the program. Bob, you can go on to the next slide, and I think with that we're at conclusion. Again, I'm Susan Heil. I'm the principal investigator. Some of you have been in contact with Tandria Hilliard or others involved with our recruitment effort. Tandria is our recruitment lead, so we provide our 2 email addresses there. But we also have an email address for the project as a whole and a phone number, so that's listed on the slide as well. And again, we provide you with our website there on this slide as well.